Thank you for viewing this provider training for the Reverse the Cycle program that is being implemented in the emergency department at Harlan ARH Hospital. Today, I will review with you the Reverse the Cycle model and how it's being implemented at Harlan. I'll also help you understand the role of the provider and one of the components of the model, which is the medication for opioid use disorders initiation in the emergency department. To give you a little background about why we are here, the Reverse the Cycle model is a comprehensive substance use response model that is designed to work in an emergency department. It has been implemented in over 50 hospitals across the nation, including Hazard ARH, Whitesburg ARH, and Beckley ARH hospitals. As we look at substance use, we recognize that it is a national public health crisis. To understand the importance of having a model like Reverse the Cycle in your emergency department, I'll provide some context and share data on substance use nationally and locally in Kentucky. In 2020, there were 41 million people who needed substance use treatment based on their risky behavior, whether that was alcohol use, prescription misuse, or other illicit substance use. However, only 4 million of those Americans were receiving treatment. And those that did not receive treatment could have been for any number of reasons, including barriers such as childcare, transportation, and health insurance. But what we find even more so is that many of those patients did not think they needed treatment. In the same year, there were over 59 million Americans who had tried an illicit substance in that month, and an estimated 100,306 Americans died from a drug overdose, which is nearly a 30% increase from the previous year. As we shift now to looking at opioid-related emergency department visits and inpatient visits, as we were beginning to see some decrease in opioid-related hospital use in 2019, moving into 2020, effects of the COVID-19 pandemic really contributed to the stark increase we see here in emergency department visits and inpatient stays over the last year for people who had been using opioids. When it comes to drug overdose deaths, our nation was hit incredibly hard in 2020. As I mentioned, according to the CDC, there were 100,306 drug overdose deaths reported in the United States last year. Roughly 69,000 of those deaths were attributed to opioid overdoses. The number of deaths attributed to overdoses in 2020 is a somber reminder that the opioid epidemic continues to deeply impact our communities. The Office of Drug Control Policy believes the global pandemic caused by COVID-19 was a major contributing factor in the rise in overdose deaths across the United States and in Kentucky. Kentucky is among the top 3 states for the spike in overdose deaths in 2020. The interruption of routine care for those in recovery, the sense of isolation, economic concerns, and anxiety all contributed to the dramatic increase recorded. Displayed here on Kentucky resident drug overdose deaths, this data shows us that from January 2019 to March 2021, we saw 1,964 Kentuckians had died from drug overdoses in 2020, a 49% increase in drug overdose deaths from 2019. In addition to the stress caused by the pandemic, reports show the increase in overdose deaths for 2020 is due to a rise in illicit fentanyl. The data displayed here was produced by the Kentucky Injury Prevention and Research Center for the Kentucky Department of Public Health. Fentanyl and methamphetamine have been identified as the biggest drivers of overdose deaths. For 2020 data, toxicology reports show that fentanyl was involved in 1,393 of the overdose autopsies, or approximately 71% of all overdose deaths for the year. Acetylfentanyl, Another version of the drug was found in over 502 of those cases. Taking a look at state-level data here, we see the national data aligns quite well with what played out in Kentucky from January 2019 through December 2020. We see fentanyl-related drug overdoses began to ramp up early 2020 and hit quite a spike in May 2020 and really has maintained high counts since the spike. Taking a closer look at the local Harlan area, in 2020, Harlan County had nearly 55 drug overdose deaths per 100,000 population of individuals. Now, you might be wondering, what can be done to confront this crisis? I'll now move on to providing an overview of how the reverse the cycle model addresses the national substance abuse epidemic we are facing. The reverse the cycle model is a comprehensive substance use response program. Harlan ARH has received funding from the Mosaic Group, a consulting firm based out of Towson, Maryland, through an award from the CDC to implement the reverse the cycle program in your hospital. There are 3 components of this program. One is universal screening and peer intervention, the overdose survivor outreach program known as OSOP, and then there is the initiation of medications for opioid use disorder in the emergency department. Now I'll walk you through how reverse the cycle will be integrated into your existing workflow in the emergency department. The reverse the cycle protocol has been approved at a system level by leadership across ARH. This protocol includes having all emergency department patients ages 18 and older being screened by their nurse during nursing assessment. The screening tools are located in Meditech and includes a series of questions used to determine a patient's risky substance use as it relates to alcohol, prescription drug misuse, and illicit drug use. If a patient scores 7 or greater on the Audit C, which is the tool to determine risky alcohol use, and or answers yes to either of the 2 drug questions asking about a patient's prescription or illicit drug use, they will be considered a positive screen. There are also what we call exclusion criteria that result in a positive screen, which I will share with you on the next slide. Here you see a screenshot of the screening tool used by nursing, which begins with the exclusion criteria. Some criteria, if met, will not lead the patient to participate in the screening. There are other criteria, if met, that will lead the patient to be considered a positive screen. For example, if a patient is under the age of 18, nonverbal, or critically ill, they will not participate in the screening. Then there is the criteria of being identified as an opioid overdose, non-opioid overdose, intoxication, or provider request, which will lead a patient to screen positive, but does not require nursing to ask the questions below pertaining to a patient's alcohol or drug use. The idea behind this is that if a patient meets either of those criteria, the likelihood of them effectively responding to those questions is impacted. Therefore, their identification alone by nursing meeting either of those criteria will lead them to screen positive. If the patient does not meet any of the exclusion criteria, then the nurse will proceed with asking the 3 Audit C questions and 2 drug use questions you see below the exclusion criteria. If a patient screens positive, they will have a peer recovery coach come into the room to speak with them about their substance use. The foundation of this program and the individuals who will be working with substance using patients in the emergency department are called peer recovery coaches. Peer recovery coaches are individuals in long-term recovery from substance use disorders that are trained in motivational interviewing and other skills to use their lived experience to help patients that are in active addiction. These individuals will have a conversation with patients who screen positive for risky or alcohol drug use and make referrals to treatment as appropriate. Harlan ARH is funded to have 2 full-time peer recovery coaches. The hours are subject to change, but will start with coverage Monday through Friday from 8 a.m. to 4:30 p.m. The peer recovery coaches will see patients in the emergency department and in the local Harlan community. The community-based work will include providing intensive outreach and follow-up with patients who have presented to the emergency department following an opioid overdose. I'll explain more about the community-based work later in the training. The second component of the program is the Overdose Survivors Outreach Program. This is that community-based work. This component of the program will help address the overdoses in Harlan County. The peer recovery coaches will provide community outreach to these survivors. The support will be offered to patients is really going to be focused on working with the patient to prevent a subsequent overdose. The peer recovery coach will have weekly and sometimes even daily contact with these patients to support their recovery. Next up, what I have displayed for you here is a visual that shows an overview of the peer recovery coach's work. It begins with all emergency department patients ages 18 and older completing a universal substance use screening with the nurse. If the patient screens positive for risky substance use, the peer recovery coach will receive an alert on their track board in the EMR that a patient with risky substance use will need to be seen. The peer recovery coach will review the patient's results on the screening, review their medical history, and the reason for the patient being in the emergency department. The peer recovery coach will then meet with the patient to have a conversation about their substance use. Based on the conversation the peer recovery coach has with the patient, in collaboration, they'll make a plan to address the patient's substance use. This plan could be anything from a referral to treatment or even just a plan to reduce use. Once the peer has spoken with the patient, if they have reported any opioid use, we want to consider them for a dose of receiving buprenorphine in the emergency department if they are motivated to go to treatment. Mosaic has implemented this in hospitals across the nation, as I mentioned, since about 2014, and it has been about 4 years since we have been working with hospitals to provide a dose of buprenorphine to patients who are opioid using and in the emergency department. Next up, I'm going to share with you an overview of that part of the program that involves patients receiving an initial dose of buprenorphine in the emergency department at Harlan. There is a great deal of research and science that supports medication-assisted treatment for opioid use disorders. This research supports that medication for opioid use disorders does save lives. It has been found that medication, like buprenorphine, is estimated to reduce mortality by up to 50%. It has been linked to reduce risk of overdose-related deaths, and the risk of opioid overdose death declines immediately when patients with opioid use disorders are initiated with buprenorphine treatment. Furthermore, buprenorphine is associated with improved social functioning, decreased IV use, reduced HIV transmission, reduced HIV diagnosis, and better quality of life. In terms of how buprenorphine works, as you know, there is a ceiling effect, so the patient cannot get high. There is also the naloxone present that blocks the opiate effect if injected. You may be familiar with the popular D'Onofrio study out of Yale, where they similarly, out of an emergency department, had 3 study groups. One was initiated with buprenorphine and a 3-day prescription, with a referral to a primary care provider with continued maintenance therapy. One group received a brief intervention and then got a referral to treatment with no medication. And the third group received a simple referral to treatment. And what you can see in terms of engagement and treatment at 30 days was their retention and any self-reported illicit opioid use, as well as their toxicology report for opioid use. The group who received buprenorphine in the emergency department with that coordinated link and bridge to care did better across all 3 components. They were retained in treatment at a rate of 78%, much higher than the other 2 groups. Their self-reported illicit opioid use was fewer days, and their urine toxicology negative was at a higher rate than the other two groups as well. When we think about practitioners using narcotics to treat opiate addiction, there is a separate registration or waiver needed. The Drug Enforcement DEA has an exception to the registration requirement, which is known as the 3-day rule, which allows practitioners who are not a waivered provider to administer, but not prescribe, narcotic drugs to patients for the purpose of relieving their acute withdrawal symptoms while a patient's referral to treatment is being arranged. Under this exception, providers that work in the emergency department are permitted to administer buprenorphine to patients for no more than 72 hours. So when we think about initiating medication in the emergency department, we know that patients who begin or are already experiencing withdrawal when they are in the emergency department could receive a combination tablet of buprenorphine and naloxone to feel better, which would allow them to participate more actively in their health care. When patients feel better, which happens almost immediately after receiving the dose, they can understand their discharge instructions better. They're less likely to leave AMA out of a fear of getting sicker. And when they feel better, they're less likely to use an illicit substance overnight before they go to treatment the following day. We also know when patients receive a dose and avoid illicit use, they're more likely to engage in treatment within 24 hours. And when we look across our hospital data, we know that patients who received a dose of buprenorphine in the emergency department show up at a rate of 65 to 70%. So there is a very high likelihood that they're going to enter treatment the following day. So the way this component works is the patient has already been screened positive and they've received a brief intervention from the peer recovery coach. Through that conversation, the peer has determined that the patient is motivated for treatment and is willing to go to care the next day. Those are really the two components the peer is figuring out, that the patient wants to go to treatment and they're willing to go the following day. At that point, the peer recovery coach is going to talk to the provider to let them know that the patient is motivated, let them know that the patient is opioid using, and let them know that the patient should be considered for a dose of buprenorphine in the emergency department. The provider is then going to assess the patient for any exclusion criteria, which I will review with you as a part of the ARH protocol. Then that provider is going to order the clinical opiate withdrawal scale. The nurse is going to conduct the clinical opiate withdrawal scale, which does exist in Meditech. If the score on the COWS, clinical opiate withdrawal scale, is 8 or greater, then the provider will order an 8 milligram dose of buprenorphine. The nurse will then administer and observe the patient is taking the medication. And meanwhile, the peer recovery coach is working to coordinate the patient's care for the following day. And I'll go into this in more detail, but those are what we call our fast track providers. These are also called fast track patients. Fast track providers are providers in the community who we have developed protocols with so that the peer recovery coaches can refer patients to them either the same day or next day for continued induction and maintenance. When a peer has recommended the patient be considered for a dose of buprenorphine, there are some exclusionary and cautionary criteria the provider should consider. So we do not want any patients to be on any long-acting opiates for pain if there's any evidence of liver disease or if the patient is in any acute psychiatric distress and are unable to consent to treatment, then we would not want to consider them. Or if the patient reports an allergy to buprenorphine or naloxone, we also want providers to proceed with caution, but not exclude the patient entirely if there is any prescribed or illicit benzodiazepine use or if the patient is pregnant. Neither of these disqualifies the patient, but we do want to make sure you feel confident dosing the patient and proceeding from there. On this slide and the next slide that will follow, I have included the MAT order set. When the peer notifies the provider that a patient should be considered for a dose, there is also a trigger that notifies you it is time to consider the patient for any exclusion or cautionary criteria. and there is a MAT order set that you will be able to follow in Meditech. You will see it includes the exclusion and cautionary criteria at the top. It also includes nursing orders for the clinical opiate withdrawal scale. The medication, which is mentioned, is an 8 milligram dose of buprenorphine, and the consult for the peer recovery coach. So this is the top half of the order set, and this is the bottom half of the order set. A part of the MOUD initiation protocol, medications for opioid use disorder, is also to make sure the patient meets the DSM-5 criteria for a substance use disorder, which is outlined here. As I mentioned, the nursing team will be doing the clinical opiate withdrawal scale. This is a series of 11 questions that the patient can score on, and any score of 8 or higher makes the patient eligible to receive a dose of buprenorphine. Displayed here is a screenshot of the clinical opiate withdrawal scale. The visual here simply gives us a picture of the empty receptor and shows how perfectly the opioid fits into the receptor. However, with the presence of buprenorphine, if there is any opioid that enters the person's system, the buprenorphine makes the receptor an imperfect fit for the opioid to nestle into the receptor. When giving patients an 8 milligram dose of buprenorphine, we have not seen a high rate of precipitated withdrawal occur. But we do know withdrawal is more likely to occur when there is a level of physical dependence that is high, or there has been a short time since the patient's last opiate use, or if that initial dose of buprenorphine is too high. So again, that is why we do the clinical opiate withdrawal scale, to make sure they are far enough into withdrawal that we might prevent precipitated withdrawal. And we look at the exclusionary and cautionary criteria as well. If the patient happens to go into precipitated withdrawal after you have administered or the nurse has administered that first dose, we recommend that you give a 4 milligram dose to the patient in addition to that in order to try and prevent or end their precipitated withdrawal. While the provider and nurse are working on administering the patient's buprenorphine, the peer recovery coach is arranging for the patient to be referred to a fast-track provider. Fast-track providers are an existing network of community providers Mosaic has worked with that have committed to receiving patients from Harlan's emergency department who has been dosed. These providers are ready and willing to accept patients from the emergency department the same day or next day for continued maintenance. Each fast-track provider has a unique protocol the peers will follow to schedule patients an appointment. The peer recovery coach will not recommend a patient to the provider to be considered for a dose unless the patient has confirmed they will attend treatment and there is likely an available appointment the following day. A few confirmed fast-track providers for Harlan include Sparrow Health, Bright Heart Health, and H&A Counseling Associates, with more to come. The Reverse the Cycle program will be going live at Harlan on February 16th. The peers are in training with Mosaic Group the week before go live. Tiffany Latham, who is a senior behavioral health consultant with the Mosaic Group, is the primary consultant working with Harlan ARH to support this program. She will be providing in-person and remote technical assistance to support the peer team and any other clinical staff throughout this process. Her phone number and email are listed here. She will be checking in with the peer team almost daily and working with the planning team to continue with the support of implementation. Thank you so much for your time, and please reach out to Tiffany with any questions that you may have. Have a great day.